Hello everyone. In this video we are going to discuss about the drug therapy in MI. This is very important question in second year pharmacology and also this will be helpful till medicine final year. This can be asked in 5 marks, in essays, in 1 marks and even in your university practical exams. So let's see this whole of this treatment. So first, drug therapies for MI is we start with knowing the fact that is ACS, around acute coronary syndrome. So this acute coronary syndrome which actually causes MI. So the MI can be it can be expressed in various situations in unstable angina, that is angina at rest, non-ST segment elevated MI, ST segment elevated MI. So these are different types of time where you can actually come across a MI. So how do you treat when a patient is coming to you with MI? So first we have to treat the patient's pain and anxiety, because when the patient is very anxious it may lead to increase of heart work, and which can increase the infarct size of the MI, right? So we have to treat the pain and anxiety first. So for that, we'll give 3 doses of GTN, glyceryl trinitrate or nitroglycerin, 5 minutes apart. So this is to reduce the workload when the patient is so anxious, okay? And morphine we give because it is opioid analgesic, it can actually relieve the pain. So we first relieve the pain and anxiety of the patient. Next we give oxygenation. So next step is actually oxygenation, because the patient will be hyperventilating, the patient will have respiratory depression, so the patient will have lower respiratory rate. So for that we have to treat the patient with proper oxygenation. Next we'll try to perfuse, because a patient's heart is not pumping well now. We have to perfuse the tissues with optimum blood. So we'll give some saline dextrose IV slow infusion to replenish the tissue perfusion. Next, coming to the heart, we have to treat any arrhythmias. We have to look up for any arrhythmias. Most of the cases there will be arrhythmias, and we have to treat arrhythmias with beta blockers. So beta blockers, they can treat arrhythmias because there is beta 1 receptors in the heart. So when you give beta blocker, it can actually decrease the heart rate. So to reduce the workload of heart and progression of MI. And beta blockers are always used when there is no contraindication. That is a very important point, because when you're using a beta blocker, when there is a contraindication, it can lead to sudden death of the patient. Next, in arrhythmias, when the patient is having tachyarrhythmias, maybe we can use something like lidocaine, procainamide, amiodarone by IV infusion. But lidocaine nowadays it is not recommended because it causes bradycardia and heart block. Okay, now we have treated the arrhythmias. Now, when there is a pump failure for the heart, so when there is a pump failure for the heart, what can we do? So when the objective is to increase the cardiac output, to decrease the filling pressure, because the pump is not working properly, so we should try to increase the pump, so we can increase the cardiac output and decrease the filling pressure, because we should always decrease the pressure of the heart, okay? So filling pressure without increasing the cardiac work. So when the cardiac work should not be increased, but we must try to increase the cardiac output and also decrease the filling pressure. How? First we'll use furosemide. Furosemide is a high ceiling loop antidiuretic. Loop diuretic. So it decreases the volume in the pulmonary when there is a pulmonary edema, when there is a pulmonary increased pressure. So we use furosemide, and which decreases the cardiac preload. So it decreases the pressure that's been put on the heart. Next, we'll use some vasodilators, right? Because when you use a vasodilators or when you use a venodilator, it can decrease the preload of the heart, or it can also decrease the peripheral resistance, so that the heart doesn't have to pump with a very force, right? So we'll use something like a GTN, that is a glycerol trinitrate. And we can use beta blockers when we use, always when you use some nitrates like nitroglycerin or isosorbent dinitrate, mononitrate, anything. When you use, you have to always use it with a beta blocker like esmolol or labetalol to decrease the adverse effects of the nitrates. Next, we'll use something like an inotropic. So inotropic means what? Increases the force of contraction of the heart. So how can you increase? So the drugs are dopamine and dobutamine. These are inotropic agent. Next is to prevent the further thrombus extension. So always when there is a myocardial infarction, the most important cause is that the thrombus is formed, and you have to prevent further formation of thrombus, right? So all these are actually the prevention part. Okay, so the first is thrombus extension. So we'll give aspirin in chewing for MI suspected. So when the patient comes to you with MI symptoms, so you should give aspirin chewing. Okay, then we'll give some antiplatelet drugs like clopidogrel, pasugrel, which is 80 to 160 milligram per day. So this is the dose. And then we'll give some anticoagulants like heparin, fondaparinux to prevent the deep vein thrombosis, because usually the MI patient, they'll always have to rest, so there is high chances for the patient to get deep vein thrombosis of the leg. So because of prolonged uh, sedentary lifestyle, so we'll give something like an anticoagulant. Next is, whatever the thrombus formed, we have to lyse the thrombus. This is prevention, but if we are here, we have to lyse the thrombus which is formed earlier. So we'll give fibrinolytics like atiplase, teniplase. But these fibrinolytics we can't give for a patient who's coming with an MI which is a severe case. We can give for the MI with sudden onset of symptom within 1 to 2 hours. When you find the patient is having MI, you can give fibrinolytics, but nowadays the most recommended part is percutaneous coronary intervention, that is a stenting process, right? So we'll most of the time